Section 1. Surgical Anatomy and Physiology, Building the Foundation.
Let's consider the sheer statistical weight of coronary dominance. The right coronary artery is dominant in 80 to 85% of cases, literally giving off the posterior descending artery most of the time. Left dominance? That only accounts for about 10 to 15%. So why does this actually matter clinically? Well, there are two massive reasons that get tested constantly. First, dominance directly dictates your target selection during a COBG. And second, it predicts the exact location, whether anterior or posterior, of the culprit vessel if you're trying to diagnose a post-MI ventricular septal defect. Moving on to an absolute exam favorite, the triangle of Koch. You've got to know these boundaries cold: the coronary sinus, the tendon of Tadaro, and the septal leaflet of the tricuspid valve. Slap right in the middle of all that, the AV node. The absolutely crucial point here is knowing exactly when that AV node is at risk for surgical injury. You've got to anticipate potential damage during a tricuspid valve repair and aortic valve replacement, specifically when you're working near the non-coronary and right coronary cusps or during mitral valve procedures anywhere near that anterior leaflet.
Let's pivot to postoperative physiology. Picture this algorithmic management for a low cardiac output state. Trace the clinical logic with me. You've got a hypotensive patient. You systematically assess three things: central venous pressure, systemic vascular resistance, and heart rate. CVP is low, you increase preload with fluid or blood. High CVP combined with high SVR, you need to reduce that afterload with vasodilators like nitroglycerin. Now, if the cardiac index is still low after all that, you immediately step up to inotropes to boost contractility, or you start considering mechanical support like an intra-aortic balloon pump. It's a very rigid, stepwise pathway to reverse a dangerous low-flow state.
Section 2. Preoperative Risk Assessment. Anticipating Complications.
Board examiners absolutely love direct cause and effect relationships, so let's just rattle these off. Patient has diabetes mellitus, you need to anticipate a much higher risk of infection and poor wound healing. Previous sternotomy or chest radiation, you go in fully expecting a really difficult dissection because of all those dense adhesions. What if they're on home oxygen or have COPD? They are at a huge risk for prolonged ventilation and strictly need pulmonary function tests beforehand. Hear a carotid bruit or see a prior stroke in their chart? That's a major CVA risk demanding a carotid Doppler. And seriously, do not overlook poor dental hygiene. A Panorex is absolutely required prior to any valve procedure to rule out hidden infectious sources.
Now, when you're looking at pre-op imaging, keep an eye out for bright white calcium deposits lining the aorta. That right there is the dreaded porcelain aorta. Spotting this on an X-ray or CT scan forces a total pivot in your operative plan. Why? Because it significantly increases the risk of an embolic stroke the second you apply a clamp. This means you have to immediately start considering alternative cannulation sites, or in really severe cases, it might even render the patient completely inoperable.
Let's lock in a golden clinical rule here. A preoperative transesophageal echocardiogram, a TEE, is considered completely mandatory before mitral valve surgery, and there's a really good reason for it. Under general anesthesia in the OR, the actual severity of mitral regurgitation can be vastly underestimated. You absolutely need that pre-anesthesia baseline to dictate whether you're going to just do a repair or if you need a full-blown replacement.
Section 3. Conduit Selection and Timing. Maximizing patency.
When you are bypassing a coronary artery, your choice of plumbing is everything. The left internal mammary artery, or LIMA, is the undisputed champion here. Why is it the gold standard? Because it boasts a massive 94% patency rate at 10 years. In fact, using the LIMA to bypass the LAD is so definitively linked to improved overall patient survival that it's an official Medicare quality measure. Now compare that to the alternatives. The radial artery gives you about 80% patency at 10 years, and the saphenous vein graft, that drops off significantly, hovering at just 50 to 60% patency once you hit that 10-year mark.
Timing is everything, right? Especially when you're dealing with antithrombotics in a stable patient. Here is the hard and fast rule. You have got to postpone an elective CABG for 5 to 7 days after discontinuing clopidogrel. There's just way too high a bleeding risk if that P2Y12 inhibitor hasn't fully cleared their system. And that exact same high bleeding risk applies to glycoprotein 2B/3A inhibitors depending on their specific half-life. You are constantly playing this balancing act, weighing the acute risk of fatal bleeding against the risk of acute renal failure from baseline creatinine issues or recent nephrotoxic dye from the cath lab.
Section 4. Cardiopulmonary Bypass Basics. The Extracorporeal Circuit. Let's trace the physiology of the extracorporeal circuit. First, deoxygenated blood is drained by gravity via the venous cannula right into a reservoir. From there, it moves into a membrane oxygenator for that vital gas exchange, passes through a heat exchanger to strictly regulate the patient's temperature, and finally, an arterial roller pump drives this freshly oxygenated blood right back into the patient through the arterial cannula.
But listen, this miracle machine, it comes with a severe physiologic toll. Introducing a patient's blood to non-endothelial surfaces immediately kicks off systemic inflammatory response syndrome, or SIRS. The patient endures a generalized low flow state, ischemia and reperfusion injuries, severe hemodilution, the literal mechanical destruction of blood cells, and the ever-present risk of gas or particulate embolization. So the absolute key takeaway is this: prolonged cardiopulmonary bypass time is an independent major risk factor for nearly every single postoperative complication. The clock is always ticking.
Section 5. CABG Indications and Outcomes. Knowing when to cut.
Okay, drill these ACC and AHA guidelines into your memory right now, because these are the absolute indications for choosing surgery. You bypass when there's greater than or equal to 50% stenosis in the left main coronary artery. You bypass for 70% or greater stenosis in 3 major coronary arteries or in the proximal LAD plus 1 other major artery. CABG is also heavily indicated for multivessel disease in a diabetic patient or when you have left ventricular dysfunction, meaning an EF between 35 and 50%, but testing proves there is still viable myocardium left to save.
And when you inevitably have to choose between a CABG and a stent, or PCI, you've got to remember the syntax trial. For complex 3-vessel disease or left main disease, CABG statistically outshines stenting. At the 1-year mark, PCI actually had inferior outcomes for those complex cases. CABG simply provides a clearer survival advantage, significantly reduces the risk of a repeat MI, and drastically lowers the need for repeat revascularization down the line.
Now, let's look at a couple of disastrous mechanical complications post-MI. Both a post-MI ventricular septal defect and a papillary muscle rupture share a terrifying clinical presentation. You've got a patient rapidly deteriorating with a brand new hollow systolic murmur. So how do you tell them apart on an exam, or better yet, in the ICU? Well, a VSD typically hits 5 days to 2 weeks post-MI, and it's diagnosed definitively by an oxygen step-up in the right heart during catheterization. Papillary muscle rupture, on the other hand, causes severe mitral regurgitation that you diagnose via echo. But note the shared endpoint here. Both require immediate intra-aortic balloon pump placement and emergent, life-saving surgery.
So I'll leave you with this final rapid-fire clinical scenario to lock it all in. When you are assessing a post-MI patient in the ICU who suddenly develops a new hollow systolic murmur and starts crashing, which critical diagnostic pathway is your mind map going to follow first? Are you hunting for an oxygen step-up or a flail mitral leaflet? Master that distinction, master this physiology, and you will absolutely master the wards. Keep revising, stay focused, and I'll catch you on the next High Yield Explainer.